Hi there, this is Dr. Alice Lee. Welcome to this month's iCubed. iCubed is EMN's latest and newest blog this year, and I'm very happy you're here to join me. Well, this month I have a new guest. He's one of our new colleagues, and I've had such great pleasure working with Dr. Craig. Why don't you introduce yourself a little bit?
My name's Kevin Craig. I'm a board-certified emergency physician at Banner Bayward Medical Center in Mesa, Arizona.
Where did you train?
Well, I attended several undergraduate institutions, including most prominently Arizona State University, and then I went to medical school at the University of Arizona. I did my residency in emergency medicine through Michigan State University at Sparrow Hospital, Level 1 Trauma Center in Lansing, Michigan. Fully intended to return to Arizona as soon as I was done, but I got stuck in the snow for 20 years. So.
Wow, I didn't know that. How long have you been practicing emergency medicine?
Well, this marks 17 years out of residency for me this year. Yeah.
That's great. Well, you've been a great addition to our group. I'm very happy that you're with us.
Thank you so much.
It's a great pleasure working with you. So let's go ahead with this case. It's a case. All my cases seem to be just, to me, so interesting. There's always some learning points, but this is a patient I saw recently, and he's a 55-year-old gentleman who we know has a history of cirrhosis, and he was brought in because he was vomiting, and he was hypotensive. Okay, so that's the little bit we hear before he comes in. Upon presentation, he's looking very sick. Okay, he's pale. We know that he's got the history of varices, so he's hypotensive. Paramedics report that he was vomiting bright red blood. When I see him in the trauma room, in our critical care room, he's semi-conscious, and he says he started vomiting blood maybe an hour before he came in. He was murmuring something about the blood coming out, the other side of him. He was awake and conscious, though. He wasn't, arresting or anything. At presentation, these are his vitals. Like that? Do you like that?
Yeah.
So his blood pressure 67/42, his heart rate is 88, he's hypothermic a little bit, and his stats are okay. When he came in, he wasn't really vomiting at the time, but I can see dry blood on his face and dry blood on his mustache. But then shortly after he got in the trauma room there, he started to vomit some semi-clotted blood. It was bright red. What do you think now?
Well, he's obviously a very sick gentleman.
Yeah.
He's going to need volume resuscitation immediately.
Yeah.
A little surprised that his heart rate isn't any faster.
Exactly, I thought so too.
Point. Yeah.
But because he's hypotensive, we got to expedite, our care right away. How would you start his workup or his treatment at this point?
Well, I'm not going to postpone treatment of this very sick gentleman.
Yeah.
Trying to start a big workup. I think immediately we need venous access, probably 2 lines. Start with whatever we have, probably normal saline, and he's almost certainly going to need blood.
Yep.
And whether or not we're able to wait for cross-match blood is going to depend on his initial response to our volume resuscitation. But my hunch is, looking at this so far, we're going to be calling probably for some O negative.
Yeah, he looks sick, right? I mean, just this description, he was sick. He was hypotensive, not just in the field. He had gotten fluid on the way in, and he was still hypotensive when he came in. So he was a really sick guy. Fortunately, he wasn't puking in front of me very much at all. But with that hypotension, you're right. We got to think it right away about giving him O-neg blood to get him tanked up. So what I did was I ordered up O-neg blood right away. I knew that he was going to be he had lost blood already. He's going to be losing more blood because he puked a little bit in front of me, right? The rest of his exam, he had clear lungs. He didn't seem to be in any kind of respiratory distress. His abdomen was really actually pretty soft and flat. But he was, semi-conscious and a little bit restless and moving about. I ordered the standard labs and all that, including type and cross, but I already called for the O-neg blood at that point. So I think it's instructive to look at this patient's time course in the ER, because this way you get a better mental picture of how things went and how sick he was. He gets into the ER at 9:21. We get a bedside H&H. The hemoglobin is 7.5 already upon presentation.
Yeah.
So he was he had just vomited an hour ago, right? So you know that the 7.5 is not accurate. It's going to be hours before it actually reflects the true loss of blood.
Sure.
So when he comes in, his vitals are these. He's very hypotensive in the beginning. He stays hypotensive. And you see within that 15, 20 minutes, he's just still really kind of unstable, right? In the meantime, we get the lines going in. We're calling for the O-neg blood. He's semi-conscious still at this point. So then at about 10 o'clock, now this is more than half an hour later, he gets the 2 units of O-neg blood. And he's still at that time hypotensive, but he's getting his blood finally. I don't know why it took so long to get O-negative emergency blood. If we look at the vitals and the time stamp during his stay in the ER, he's mostly through his ER stay most of the time hypotensive despite the O-neg, right? 2 units I gave him. I looked at his chart, and a week before this episode, he had been admitted for upper GI bleed.
I see.
That was his very first time. And he had been scoped by one of our GI guys, and he had gastric and esophageal varices. So this would be like a re-bleed. And because he was getting sicker and sicker in the ER, I decided I'm just going to intubate the guy. I have to protect his airway. He was hypotensive, and I just have to. So I did get in touch with the GI doctor who scoped him last week. And the GI guy goes, he needs a stat tips. I'm like, okay. I call radiology, and the radiologist says, there's no such thing as a stat tips.
Okay.
So, because I had never heard of a stat tips, right?
Right.
Anyway, in terms of the emergency course, it was a very quick, brief course. He was very, very sick. He needed blood. He needed to be intubated, airway to be protected because he's going to get scoped, right? So I sent him off to the ICU. And that's kind of how that case went. Any ideas, any other suggestions that you would have done?
I mean, in terms of medical therapy, in addition to, I'm sure he's probably on a proton pump inhibitor. Right. I certainly would have started a PPI infusion.
Right.
Maybe
in the ER, yeah.
In conference with GI, I would have asked if they, wanted me to start sandostatin or
octreotide in the ER.
Right.
I tried.
And then fluids are the pressor here, but if he's hypoperfusing, if he's confused, I guess I'd have considered a pressor at that point as well.
Right. I think with him, I put him on Norepi. I put him on the octreotide. I put him on Protonics. I gave him blood and got GI involved very quickly because the definitive care wasn't going to be mine. It was going to be gastroenterology to scope him and stop the bleeding. The rest of the hospital course, so I intubate him. I send him to the ICU. I give him blood. I put him all these meds, pressors. His daughter was his MPOA. She wasn't in the ER when he came in, and I intubate him and, do all that to resuscitate him. She told the gastroenterologist, this is information I find out later on, but she talked to the gastroenterologist over the phone that he wanted to be DNR. He didn't want to be intubated and all this stuff. And so they extubated him in the ICU later that day that he was admitted. He wakes up in the hospital and he tells the nurse, no, I told her I wanted everything done unless my brain isn't working.
Oh, no.
Yeah. So he was made full code rather than DNR, and then he was transferred to Banner UMC for an emergency TIPS.
Wow.
Yeah, exactly, right?
It's incredible. So often the POAs are not present in the ER when we're caring for these people, and a lot of times we'll get a code status and it's just it's hearsay,
right?
And we can't we can't adhere to hearsay. So yeah, that's amazing. It
is amazing. So then he gets transferred. After he was transferred to Banner UMC, he underwent something called a BRTO. Have you heard of that, Kevin?
No.
I can't even pronounce it. It's a balloon occluded retrograde transvenous obliteration. Anyway, so I read up a little bit about it. It has been actually over the past 10, 20 years, very commonly used procedure in Asia for gastric variceal bleeding. But BRTO is becoming more and more apparently accepted procedure here in the United States. So this patient had been transferred because he wanted more done. He wanted, definitive care and whatnot. So he was transferred to Urbana UMC. He had the BRTO procedure done and was recovering on the floor, but he re-bled 4 days after the procedure.
Yeah.
Yeah. And so at that point, he was really, really, really sick. I mean, he was in the ICU, he was on pressors and all. And so at that point, he was made DNR, and he died 5 days after the BRTO, which was 8 days after he came to our ER when I saw him. And it was 14 days, so 2 weeks after that first bleed when he was first scoped.
Yeah.
Yeah, so pretty sick.
Yeah.
So Kevin, for each of my screencasts, there's two learning focuses. So let's go through that. Guess what the first learning focus is going to be on this podcast or on this screencast?
Paracel hemorrhages.
Yes. So, there's actually a couple of recent articles that were great articles. This one was published just in May of this year in Gastroenterology Reports, and the title is Recent Advances in the Management of Variceal Bleed. So when I looked through this article, I had some terrific learning points, so let's go through that. The authors talk about, just in general, that over the past 20 to 30 years, there's been just really a marked improvement of survival of variceal bleeds. Back in the 1980s, the 6-week mortality was 40 to 50%. Incredible. Wow. Yeah, wow. Incredible, right? So 37 years ago, at that time, the 6-week rebleeding rate was a third of these variceal bleeders. But then in 2014, apparently a study had shown that a 30-day mortality rate had improved so much. It had improved to 15%, and the rebleed was down to a 26% rate.
Is that because these patients are going for TIPS?
Well, so that's a good question. It's because the approach now has changed. They used to have just sort of this one-size-fits-all strategy to treat all these variceal bleeds. It's the same kind of way, which is surgical or take them to the suite for endoscopy. But it's become more and more individualized. So they're trying to prevent that first index bleed. They are assessing all the cirrhotics early and risk stratifying them. And so that's what they think that the paper talks about in terms of why the mortality's improved so much. Fun facts. So fun facts about varices. I learned a lot reading this article. So number one, 50% of cirrhotics have varices, which to me, I thought they all had them, but only 50% apparently of cirrhotics have varices. 20% of cirrhotics have gastric varices. Wow. Yeah. A very important measure is something called the Hepatovenous pressure gradient, Hpvg, which is essentially an estimate of the pressure gradient between the portal vein and the inferior vena cava, and that they use that the number of 20 millimeters. If the Hpvg is greater than 20 millimeters, it will increase the rate of hemorrhage. So when they're assessing the cirrhotics, they'll gather these points, so they can risk stratify them. The rate of variceal bleeding is only, believe it or not, 5 to 15%. I'm a little surprised. And that's, I guess, modern numbers, it was probably higher earlier on or decades ago. The fun fact number 5, mortality of your index bleed at 6 weeks is 20%. So 20% of these variceal bleeders, I guess, died.
That's amazing.
In about 6 weeks. Yeah, that's a pretty high mortality rate. Gastric varices bleed less, but if they do bleed, they have a higher mortality. And that kind of makes sense. It's harder to tamp a knot that and fix that probably. And then fun fact number 7, the primary way to prevent index bleeding is the non-specific beta blockers or variceal band ligations.
Which may explain that gentleman's heart rate on arrival.
Right. Especially since he had just been seen by GI,
right,
a week before. So I'm sure they started him on the prophylaxis. I found another article that was really quite instructive, interesting. And again, it was published this year, January of 2017. These are the recommendations from this article. They recommend that you transfuse at about 7, hemoglobin of 7, but no higher than 9, meaning don't transfuse above 9. It would increase the portal pressure and increase bleeding.
That makes sense.
Yeah. And this I didn't know. They recommend short-term antibiotic prophylaxis for any cirrhotics with a GI hemorrhage. Did you know that?
No,
I did not know that. Yeah, no, I did not know that. And it's Rocephin, gorillacillin. It's all Rocephin can be used for so many things. They recommend that we use octreotide for variceal bleeds, which I did. And then they recommend endoscopy within the first 12 hours of the bleed for variceal band ligation. All of these cirrhotics probably have an elevated INR, but they don't recommend correcting that.
Yeah, I mean, they're all, I'm sure, profound coagulopaths, and not only are they probably thrombocytopenic, but these liver failure patients, their platelet function is abysmal as well.
Yeah,
so
exactly.
even the platelets they do have are not working.
Right, exactly. And apparently the INR being elevated, it's not correctable anyway by fresh frozen or PCC, whatever. So they don't recommend it. In terms of the platelets, though, there's no formal recommendation. It's not like you should or you shouldn't. They just don't have any recommendations for what to do with thrombocytopenia. And then consider emergent tips within 72 hours if the patient is admitted and rebleeds within that 3 days. So my patient, the GI doctor who had seen him, was telling me to call for a stat tips. It was funny because I'd never heard that, and when I talked to the radiologist, it was like, no, we don't have a stat tips on this guy. But I learned a lot by reading these articles, and now I think definitely I'm more prepared to take care of a variceal bleeder. So, learning focus number 2 on this patient. I've never had a very, very serious variceal bleeder in front of me where they're actually hemorrhaging. What would you do?
Well, all the things we've talked about, I suppose ultimately there's always the Blakemore tube.
Yeah. I've never had to use one. It seems to me to be fairly simple procedure. We put tubes and orifices and we put lines and all that. So I actually went on YouTube and then I looked at the MCRID's video, and it looks like it's pretty simple. There's 3 ports for the Blakemore tube. There's a gastric port that you suction through, and then there's the esophageal balloon port, and then there's a gastric balloon port. And it's just a matter of looking at the video itself, or you can just read up. It's pretty simple putting those balloons, attach them to a 3-way stopcock, and then you just have to inflate each balloon sequentially. You have to inflate the stomach one first. You have to identify and confirm that it's in the stomach by using a portable X-ray. You can see the large gas bubble, and then the esophageal balloon is not determined by the volume. It's really the pressure in the esophagus. So if you inflate the esophagus balloon, you just have to have a manometer attached to the esophageal balloon port. Either the manometer, you can like a portable handheld manometer, or you can actually use a the bedside manometer. We take off the rubber curly tubing. You can attach that to the esophageal balloon port, and that'll measure the pressure. So the pressure in the esophagus is really you want it to be about 30 to 40 millimeters mercury.
You want to overcome that gradient.
Yeah, so it's really not a matter of how many cc's of air you infuse or input to the esophageal balloon versus the gastric balloon. You actually have to put in like 300 cc's of air to
filling a large space.
To make it work. But the inflation of the esophageal balloon is based on the pressure, not the volume of air you put in there. That's your basic sort of Blakemore tube insertion. And then after you put it in, or orally, there's a ways of rigging up a way to just have constant pull on it by hooking it to a football helmet on the patient, or you can actually hang it off of a IV rack by attaching the end of your Blakemore tube to like a liter bag of saline, which is apparently 1 kilogram. But anyway, it's not a real difficult procedure. You just have to kind of to familiarize it once, and then I'm sure everybody can do it because we're all very adept at doing procedures in emergency medicine. With this patient, I was very fortunate and grateful that he didn't start vomiting in front of me. But if he were to hemorrhage in front of me, the Blakemore tube would be the recommended rescue. Well, Dr. Craig, thank you so much for joining me this week.
You're so welcome.
It's been a pleasure. I hope that you've learned something as well as enjoy this experience.
I did, yes.
That's great.
Yes.
So thanks everybody for watching and listening this month. I hope you come back again, and I hope that you've learned something from our little discussion here. We'll see you next month. Thanks. Bye.
Bye. I don't know. Maybe I was nervous.
That's all right. No, that's good. I'm going to make you sound better.
All right.
Don't you worry.
I'll do better next time.
All right.
Next time.